Hello guys. Something very sad happened yesterday. As I was doing our chat or our discussion on breast messes, so I didn't realize that my battery had died. So I kept recording, only to find out that at the end I only have about 20 minutes of the teaching, and the rest was like not there. So I want to finish that part that I couldn't record yesterday. I hope you're enjoying this breast mess series. So let's jump into it. I would recommend that you guys, before you come and watch this one, please go and check the part 1 that we did yesterday. Yeah, because this is gonna be part 2. So we said yesterday that a patient that comes in with a mass in the breast, yes, you will take your history and then you will do your triple assessment. Triple assessment. Triple assessment, we spoke about it. It's physical examination, it's imaging. Number 3, it's histology. So that is biopsy, true cut biopsy. So we spoke about this, we spoke about this part, but as a continuation I would like to start from here. So like I said yesterday, that when you take a biopsy to the lab, your pathologist should come back with 5 things on their report. They should tell you about 5 things of that tissue that you sent to them. Number 1, they should tell you about whether the cells there are benign or they are malignant. If they are malignant, they should tell you if it's ductal or if it's a lobular cancer. And they should also tell you if it's ductal carcinoma in situ or if it's invasive. Under lobular as well, they should tell you if it's a lobular carcinoma in situ or if it's invasive. So remember, the word in situ means that the tumor is not infiltrating the basement membrane. So it has not gone through the basement membrane. So it's still localized. It has not gone through to the basement membrane. That's the word in situ. And by definition, in situ or in situ cancers are not true cancers because they don't invade neighboring structures. Like I'm saying now, they don't go through the basement membrane. So, but with this one, a lobular carcinoma in situ has got a chance of it being malignant. So it's good to excise it and take it out. And we know under invasive cancers, ductal cancers, we've got about 5 types there. We have papillary, we have medullary, we have mucinous, we have cribriform, we have cubular. Those are the types there. So this is the first thing that he must tell you, the report. Second and third. Then the 4th thing that the report must tell you is the receptor status. Receptor status of that tumor. Like we said yesterday, a tumor can express estrogen receptors, or it can express progesterone receptors, or the HER2 receptors. So a tumor that is positive for estrogen receptors, it means that that tumor is dependent on estrogen to grow. The same thing applies with the progesterone. A tumor that expresses progesterone receptors, it means that that tumor, for it to grow, it depends on the progesterone. So which means if you cut off the supply of the estrogen or the progesterone, those tumors are going to shrink because you have cut off the thing that makes them to grow. The same thing applies with the head too. So it's important because once you get the receptor status, you can decide, based on this, you will decide if this patient can benefit from hormonal therapy or they will not benefit. So that's why the receptor status is very important. Okay, while we are still at it, if a cancer expresses estrogen receptors, that's good. There's a drug for that, tamoxifen. If a drug expresses HER2 receptors, there's a drug for that, trastuzumab. So, but if a tumor does not express any of these three, that tumor is called a triple negative tumor. A triple negative tumor. And these tumors are aggressive and they are difficult to manage. Okay, moving forward. The last thing is the Ki-67. This is like the proliferative or the proliferation index of the tumor. I need to check the implications of this as well. But these are the things that you're gonna see on your pathology report. So let's say now we've got this. What next? What next? We know that the patient that came with a breast mass to us, we took a history, did a triple assessment. Now the assessment is telling us this patient has got a tumor. So now what is next? The next thing is to TNM stage the tumor. TNM. So tumor, the T there stands for tumor. The N stands for nodes, lymph nodes. The M stands for metastasis. Metastasis. So this is all about the tumor size. All about the tumor size. So, like for instance, a T1, there's a TX, a T0, but I'm going to start from a T1. T1, T2, T3, a T4. A T1 is a tumor that is less than 2 centimeters. A T2, a tumor that is between 2 to 5 centimeters. T3, a tumor that is more than 5 centimeters. A T4 is a tumor that invades the chest wall or the skin of the breast. So that's the tumor size. I'm going to put this here. This tumor is not operable. I just want to put it right away that this tumor is not operable. So that you know, tumors that can be operable are these ones. And if this, okay, let me finish the thingy. So this is the nodal status. Remember, the breast is like this, ne? Is like this. Sorry. So the breast is like this. Let's say it's like this. And the breast, remember, we also remember the drainage, the lymph drainage of the breast can drain to this side, but majority goes to the axilla. It can drain to the nodes that are on the chest, next to the sternum, or to the abdomen, but majority they go this side. So they go to the axilla. So when you get here, there's a pect minor muscle. So nodes that are below this are called your level 1. This is very important. Nodes that are behind this are called your level 2. Nodes that are next to the clavicle are called your level 3. So the nodal status, if a tumor is said to be in N3, it means that these nodes here are involved, meaning your infraclavicular nodes, your supraclavicular nodes, or your internal mammary lymph nodes are also involved. That's an N3. If someone says that's an N3, right? That's an N2 and an N1 is when these level 1 and level 2 nodes are involved. This is level 3 nodes are involved there. But if a tumor is N2 and N1, it's level 1 and level 2. Level 1 and level 2. So if you do an examination and you palpate lymph nodes that are below the pec minor, and you can feel that these nodes are got a hard, then there is metastasis to them. What differentiates N1 from N2 is that with N1, the nodes are still mobile, but N2, they are fixed to the skin. They are fixed, they are not mobile. So that's what differentiates N1 and N2. And like I said, the only N that can be operated here is N1. Meaning you can do NX and N0. These ones are operable, but N1 is not operable. So if, according to a TNM classification, you find a T4, that cancer will not be operated. It's not operable. And if, according to a TNM, you find an N2 and N3, that cancer will not be operated. The reason why this cancer is not operated is because the chances of metastasis are very high once you get your N2 nodes like that fixed to the skin and affecting your level 3 lymph nodes. That cancer will not be operated. This is like very, very, very general rule. Now moving on to M. And M can either be an M0, MX, M0, and M1. And M1 is proven distant metastasis. So there is metastasis, there is mets here. Be it to the brain, to the liver, to the spinal cord, to the vertebral column, or to the chest, to the lungs. Anyway, so that's metastasis. This cancer will not be operated because there is metastasis already. If that cancer is operated, if a patient who's got an M1 is operated, it means that it's a palliative operation. It's not really a curative operation. I hope you get that. I hope you get that. So what I want also to explain is what cancers. Okay, let me just do it this way. Like I said, T1, T2, and T3, those are operable. N0 and N1, those are operable. And then M0, this is operable, but M1 is not operable. That's the general rule. So now, and so what I'm trying to say is, if, let's say they tell you that, let's say it's oral exams or it's written, they give you a scenario. They say, okay, we've got a breast cancer patient who's T this, N this, and M this according to the TNM classification. What you must do, just look at the T. Is the T T4 or not? If it's a T4, then you know that patient will not be operated. But if it's between, if it's less than, it's not it's a T3 or a T2 or a T1 or even T0, then that cancer will be operable. But now the next thing, before you say operable, look at the N. If the N is here, is N3 or N2, because of the N, the T might agree that the cancer must be operated, but if the N disagrees, then you won't operate. Because you look at the T and the N and the M, you might have a T that is low, like a T2, and an N that is N0 or N1, let's say N1, but there is an M, but the tumor is M1, then it's metastasis, then you won't operate that cancer. So you just look at, so you look at the T, look at the N, and look at the M. Where is it in terms of that? I don't know if I'm making sense. Like for instance, if someone says, I've got a T whatever T and an N whatever N, but the M is 1, the minute they say M is 1, that's not an operable cancer. They can say whatever, if the T also is 4, what N whatever, or M whatever, that because of the T that is being 4, that cancer is not operable as well. So you look at that, you decide. So by generally, look at the T, look at the N, and look at the, because you might have a T2 but an N3. Because of the N3, that cancer will not be operated. So that's the general rule, but I want you guys to go and look at this. And also you must also understand the management of these kind of patients. So if now, let's say you decide that your cancer is operable. So meaning it's a combination of these and these and this. Whatever combination, you decide this cancer is operable. What are the options? So number one, we've got what is called a breast conserving therapy. A breast conserving therapy means that the T is at a stage where it can be operated. It's not a T4. And also the N agrees that this cancer should be operated. And also there is no metastasis. Then you can do a breast conserving therapy. A breast conserving therapy, so these are the components. So you do a breast conserving surgery. Remember, breast conserving therapy is made up of a breast conserving surgery. And what is that surgery? That surgery, you make a wide, some people call it a wide local incision. So you make a wide local incision. We are trying to take out the tumor. And as you take out the tumor, you make sure that if this is the tumor, as you make a wide local incision, you make sure that you also excise around the tumor up to about 1 centimeters. So you clear the margins. It's called clearing the margins. Because if you only take this, the cells that are here that you are leaving behind will develop, you give them a chance of regrowing and the cancer grows again. So what you do is you remove the cancer and you measure 1 centimeters away from that, and then you excise all of this. So when you do this, you save the breast. You don't take out the whole breast. You just do a wide local excision. This I will explain now about mastectomy, the difference between this and mastectomy. So that's breast conserving surgery. This surgery is good when a cancer is operable and the N agrees and there's no metastasis. So it doesn't make sense to do a breast conserving therapy on a patient that has got an N3 or an M1 or a T4. And also it doesn't make sense to do a breast conserving surgery on a patient who's got multiple masses, like multiple cancerous cells in one breast. It won't be cosmetically good. So those are the things that you look at. So after doing a breast conserving surgery, you send the patient for radiotherapy to make sure that whatever cells that are remaining here, you still bend those. So that's a breast conserving therapy. And then there's what we called a modified radical mastectomy. You know, this, in the olden days, they used to do mastectomy. Mastectomy or traditional mastectomy is the removal. You remove the nipple, you remove the areola, you remove the breast tissue, you remove the pec minor muscle. That's a mastectomy. But a modified radical mastectomy, you only remove the nipple, the areola, and the breast, but you don't remove the pec muscle. So that's a modified. So if you want to do surgery, but you've got contraindications to a breast conserving therapy or breast conserving surgery, then you can do a modified radical mastectomy. I've seen a lot of patients that have been done a mastectomy, and it's documented that they've done a mastectomy. And I've seen a few that have been done an MRM. So these are the options that we have. And then after, okay, that's that. And then what's available for these patients that have got, that cannot be operated? Those ones, you can do systematic treatment, meaning you can use your hormonal treatment, you can use your radiotherapy, you can use your chemotherapy, all those things. So those are the available treatment modalities for these patients. One thing that I forgot to mention is the workup of these patients, because how do you wake up metastasis? So to make sure that you don't have this guy before you can consider a breast conserving therapy or a modified radical mastectomy, you need to make sure that you rule out the M. So you investigate that patient. So the bloods that you do, so you want to make sure that there is no metastasis. So what is the workup for those patients? You do a bone scan, you do a chest x-ray, you do a CEA, you do CA 15-3, you do FBC, LFTs, you do UNEs, you do abdominal ultrasound or abdominopelvic ultrasound to make sure that the patient doesn't have any metastasis anywhere before you can consider this. So guys, I know that breast cancer is a lot. This is just a guide. You guys will still need to go deeper and look at it. So thank you so much for watching.